Hi, everybody. This is Dr. Brett Talley Daniel, MD, giving another migraine podcast. This will be number 8, and it's on migraine comorbidities. So, definition of terms. What is comorbidity? The word comorbidity refers to a greater than coincidental association of two conditions in the same individual. It means that two medical problems occur together in the same patient more likely than by chance. Migraine is a common medical problem, and for women, the most prevalent illness women have. 20% of women and 6% of men have migraine. The most painful conditions known to men are kidney stone, pregnancy, and a migraine headache. Migraine is the 5th most prevalent disabling condition and the 10th most frequent reason to go to the emergency room. So comorbidity would be like saying ham and eggs go together and salt and pepper go together. Migraine headaches consist not only of severe, usually one-sided headache, but also of the symptoms of sensitivity to light, odors, and sound. Migraine turns on the brainstem generator for nausea and makes the person nauseated or vomit or sick. It's called sick headache. Migraine makes a person want to be still and lie down, usually in a dark, quiet room rather than being up and about. The medical conditions that link to migraine are discussed below. So this is a list of migraine comorbidities. Number 1, respiratory condition. Well, the main entries here are allergic rhinitis and asthma, which have a 17% link to migraine. Allergic rhinitis is commonly called by the men on the street sinus or hay fever. Rhino refers to the nose. Think of a rhinoceros here. And allergic refers to the genetically inherited condition of overreaction of the immune system to foreign antigens like cedar pollen or cat dander. A common lay idea is that a medical condition exists called allergy headache, but this is mistaken, and the word allergy is not even listed in the index of the Third International Classification of Headache Disorders. An allergic reaction is an antigen-antibody reaction where the antigen is a foreign protein like cedar pollen, and the antibody is another complex protein made by the immune system. This reaction causes mast cells to release histamine, and histamine causes most of the allergic symptoms of itchy, red, swollen eyes, nasal congestion, sneezing, production of clear nasal fluid, and tearing from the eyes. This relates to an allergic condition. The release of internal neurochemicals of CGRP, neurokinin A, and substance P from the arterial and trigeminal nerve ganglia occurs during a migraine headache. These neurochemicals inflame the cerebral arteries, the trigeminal nerve, and the brain pain center called the thalamus, resulting in a severe migraine headache. And that all relates to migraine. Many different chemicals cause vasodilatation and therefore aggravate migraine headaches. That's why MSG, chocolate, tyramine in aged cheese, and nitrates in hot dogs may aggravate migraine. There is a relationship between the ingestion of such a chemical and headache, but the headache comes from vasodilatation caused by the offending chemical, like chocolate, but not from an allergic reaction, which is an antigen-antibody reaction, mast cells, release of histamine. Thus, if a patient is suffering from severe allergic symptoms and is stressed by these symptoms and not sleeping well and feeling lousy at work, and if they've inherited the migraine gene, they may have indirectly more migraines, but there's no direct relationship between allergic rhinitis and migraine. They are separate medical problems. The second under respiratory here is asthma, which has a lifetime prevalence with allergic rhinitis of 50 to 100% among adults with asthma in Europe and in the United States. Asthma has a strong link to psychiatric problems such as depression, generalized anxiety disorder, and post-traumatic stress disorder. With migraine, the cerebral arteries dilate, but with asthma, the small lung bronchioles constrict, leading to reduced oxygen passage and producing the characteristic and diagnostic asthmatic symptom of an inspiratory wheeze as the air tries to pass through a narrow tubular passage. The wheeze sounds like this. Adrenaline-type inhalers used to treat asthma may also produce anxiety and panic-like symptoms. Next section, cardiovascular diseases. Stroke, particularly ischemic cerebral infarction, is increased with migraine with aura by 6%. This risk may be aggravated by taking an estrogen-based birth control treatment such as a pill or a patch or a shot. Hypertension is one of the most common risk factors for the development of atherosclerotic hardening and narrowing of the arteries. Hypertension has a 10% link to migraine. Hypertension can relate to the anxiety disorders also. Angina, myocardial infarction, that's a heart attack. Angina is chest-related or arm, chin, back, or neck-referred pain that comes with exertion or anxiety. Angina relates to heart disease. It's a man in Minnesota who shovels snow in the driveway for 10 minutes and gets chest pain. Chest pain is always serious and should be thoroughly evaluated as related to the heart, but the patient has been examined by a cardiologist and had appropriate treatment. He may be given nitroglycerin, which is a coronary artery dilating medication to take for his chest pain. The precise biological mechanism by which migraine, with and without aura, may increase the risk of myocardial infarction is currently unknown, but they are statistically relevant and do link together. Raynaud's disease and Raynaud's phenomenon are associated with migraine. Raynaud's phenomenon and disease are neurovascular symptoms relating to constriction and dilatation of small arteries. It's a sensitive reaction to temperature change of exposure, usually to cold, but also to heat and emotional event, whereby a person's fingers and toes tingle and then turn white, red, and then blue. Raynaud's disease is associated with and may be a marker for autoimmune medical problems such as lupus erythematosus or rheumatoid arthritis, while Raynaud's phenomenon is more benign and occurs without association with any other medical problems. Migraine is another disorder involving vasoconstriction and dilatation of cerebral arteries like the Raynaud problems. Congenital heart disease. A recent study found increased the prevalence of migraine among adults with congenital heart disease. The frequency of migraine was highest among congenital heart disease subjects with right to left shunt, which is 52%, followed by those with left to right shunt, which is 44% link to migraine. Mitral valve prolapse. Mitral is a common heart condition. Mitral valve prolapse is a common heart condition found in 1.5 to 2% of the population. And in most persons, does not cause symptoms. It results from descent of part of the mitral valve on the left side of the heart between the small chamber, the atrium, and the large chamber that pumps blood into the body, the ventricles. Mitral valve prolapse symptoms are chest pain, rapid heartbeat, and anxiety. The relationship between migraine and mitral valve prolapse is uncertain, yet the association has been reported. The diagnosis can be made by listening to the heart with a stethoscope, by a cardiologist, or by doing a scan of the heart. Patent foramen ovale, PFO, is found in as many as 25% of persons early in life and usually spontaneously closes on its own. Yet, patent foramen ovale may extend into adulthood and be associated with migraine. And in many individuals, as many as 25% or more, however, the foramen ovale may persist unclosed. It's patent, that means open. There's a hole in the heart into adulthood. A number of studies have suggested that individuals with migraine are more likely to have a patent foramen ovale, and this association is most evident in those whose attacks of migraine may be accompanied by an aura, usually like the visual aura. The means by which a patent foramen ovale may relate to migraine is not understood, yet there is a statistical relationship between the two. Most of the literature has clustered around PFO and migraine with aura. One theory is that blood components, which are normally screened in the lungs, would pass through an open PFO to the brain, thereby activate migraine. Surgical closure of a PFO has been associated with reduction of migraine with R in some patients, but a special study to see if there is a statistical relationship failed to support surgery. Currently, transfemoral catheterization closure of a PFO is not considered to be a viable part of treatment for migraine prevention. Next item, atrial septal defect, ASD, is statistically related to migraine, yet like PFO, surgery to close the defect is not medically indicated. Next classification level, number 3, is endocrinological problems that relate to migraine. And this is mainly hypothyroidism, which is statistically related to migraine, and treatment of hypothyroidism lowers the severity and frequency of migraine attacks. Migraine patients should have their thyroid profile studied. Number 4, dermatological. Psoriasis is related to multiple medical comorbid conditions, including cardiovascular disease, which includes stroke, ischemic heart disease, congestive heart failure, hypertension, and also metabolic disorders like dyslipidemia, obesity, insulin resistance, and type 2 diabetes. Psoriasis also relates to migraine, although how it increases the risk of migraine is uncertain. One theory is that a link between psoriasis and migraine may be due to endothelial inflammation, and nervous system involvement. Number 5, gastrointestinal problems. GI disorders have an increased frequency in patients with migraine compared to the general population. And these are Helicobacter pylori infection, irritable bowel syndrome, gastroparesis, hepatobiliary disorders, celiac disease, and alterations in the microbiota have been linked to the occurrence of migraine. Several mechanisms involving the gut-brain axis, such as a chronic inflammatory response with inflammatory and vasoactive mediators passing to the circulatory system, intestinal microbiota modulation of the enteric immunological milieu, and dysfunction of the autonomic and enteric nervous system have been postulated to explain these associations. However, the precise mechanisms and pathways related to the gut-brain axis in migraine are not fully understood, yet there's a very large literature linking migraine to GI disease. Irritable bowel syndrome is one of the most GI problems that has a relationship with migraine, present in 60% link between IBS, irritable bowel syndrome, and migraine. Migraine and IBS also strongly linked to psychiatric disorders such as chronic insomnia, generalized anxiety disorder, and depression. A research study showed that chronic headaches were reported by 30% of patients with celiac disease, 56 of those who were gluten sensitive, 25% of those with inflammatory bowel disease, and 14% of those without the conditions. Persons with celiac disease, gluten sensitivity, inflammatory bowel disease all have more migraine headaches than people without these conditions. Number 6, rheumatologic. Fibromyalgia links to migraine with a 17% comorbidity rate. Both conditions have been found to cause central sensitization, which means inflammation of the main brain pain center, the thalamus. Both migraine and fibromyalgia can cause allodynia, which is a condition whereby touch, which is usually not perceived as painful, is found to be painful. Allodynia is found with stage 4 of the migraine timing cycle with chronic migraine due to medication overuse headache. It's due to central sensitization because the central nervous system, the trigeminal nucleus, and cutaneous scalp fibers are inflamed. After a sunburn, touch of the involved skin area hurts. The touch fibers in the skin of the back and shoulders are inflamed by the burning of the sun. Wearing a shirt or a jacket over a sunburned shoulder or arm would be perceived as painful, not as just touch, which is normal. Touch of one side of the head during a migraine may also hurt, as the pain sensory fibers are activated. Activities that may cause pain with allodynia are combing or brushing the hair, wearing a hat, earrings, a necklace, glasses, or lying in bed on the involved side of the head, like a headache on the right, lying on the right side of the head may hurt. All of these so-called touch activities may hurt in a person who has allodynia related to medication overuse headache or fibromyalgia. Chronic migraine has also been shown to increase episodes of pain in persons with fibromyalgia, among other symptoms such as high-frequency headache, sleep disturbances, and anxiety. Light, noise, and touch can act as triggers to both migraine and fibromyalgia. Fibromyalgia and migraine are commonly comorbid disorders. There's a high prevalence of fibromyalgia in migraineurs and a high prevalence of migraine and other headaches in patients with fibromyalgia, like tension-type headache occurs with fibromyalgia also. Studies have found reports of increased headache-related disability, depression, and headache severity in patients with comorbid fibromyalgia and migraine as compared to those with migraine only. The presence of fibromyalgia has been correlated with low quality of life in patients with migraine, making it important to screen for symptoms of fibromyalgia in the migraine population. Neurologic symptoms. Epilepsy. Migraine and epilepsy are comorbid episodic paroxysmal neurologic disorders. The prevalence of epilepsy is 0.5% and migraine is 12%. 6% of patients with migraine have epilepsy, and 8 to 15% of patients with epilepsy have migraine. A migraine aura may trigger a seizure an hour later. That's called migralepsy, migralepsy, and a seizure may trigger a migraine attack. Research published in the epilepsy journal called Epilepsia in 2013 first investigated the role of genetics in the co-occurrence of migraine and epilepsy. The results showed a history of migraine with aura was significantly increased in enrolled participants with 2 or more additional affected first-degree relatives, supporting the hypothesis of a shared genetic susceptibility for migraine and epilepsy. Migraine and epilepsy may both be treated with neuronally active drugs like Depakote and Topamax and gabapentin, which says something about the relationship of the inherent brain abnormality of both conditions. Tension-type headaches have been found in multiple research studies to be associated with epilepsy. Multiple sclerosis. Migraine occurs 2 to 3 times more frequently with patients with MS than the general population. Clinical overlap between migraine and MS has been recognized since 1952 when a study by McAlpine and Comston observed that 2% of patients with MS develop migraine within 3 months of an initial relapse. A higher overall prevalence of migraine and MS has been supported by multiple controlled and uncontrolled studies reporting rates between 21% and 69% comorbidity between MS and migraine. 8. Psychiatric conditions. Mood disorders. Depression may link to migraine 50% of the time as the most common associated psychiatric conditions in patients with migraine. Depressive symptoms may be mood with anxiety, apathy, general discontent, guilt, hopelessness, loss of interest or pleasure in activity, mood swings, or sadness. Behavioral changes, agitation, excessive crying, irritability, restlessness, or social isolation. Sleep changes, so there's early awakening, excess sleepiness. Hypersomnia would be that. Insomnia, or not sleeping well, or restless sleep. Whole body change. There can be excessive hunger, fatigue, or loss of appetite. Cognitive changes, lack of concentration, slowness in activity, or thoughts of suicide. Weight changes. Weight gain could be up or down, usually down. There could be a poor appetite, or repeatedly going over thoughts with depression. Depressive disorders occur in patients with partial complex seizure disorders of temporal and frontal lobe origin. Depression is more common in poorly controlled epilepsy and may precede the later development of seizures. Animal models of epilepsy show decreased activation of serotonin, norepinephrine, dopamine, and GABA, which facilitates the kindling process of seizure foci. worsen seizure frequency and severity, and reversed or blocked by antidepressant drugs. There's also a relationship between migraine and dysphoria and epilepsy, described as intermittent dysphoric disorder between seizures, was first described by Emil Kraepelin in 1923, and this disorder consists of a set of symptoms found in 17% of patients with chronic epilepsy. Dysphoria is from the Greek word that means to bear it, and it's a profound state of unease or dissatisfaction. In a psychiatric context, dysphoria may accompany depression, anxiety, or agitation. The most common symptom of intermittent dysphoric mood disorder is intermittent dysphoric mood in between seizures. Interictal, which means between seizures, dysphoric disorder, can often be treated with a combination of antidepressants and anticonvulsant medication. Symptoms with this dysphoria may be depressive moods, irritability, anergia, means no energy, insomnia, pains, phobic fears, and euphoric moods. The diagnosis of dysphoria with intermittent dysphoria with epilepsy should be made when at least 3 of the 8 symptoms are present. There's also a relationship with bipolar disorder, which used to be called manic depressive disorder, and this consists of alternating mood states of mostly being mildly or severely depressed or down, alternating with times of mild or severe mania. Between 25 and 40% of patients who have bipolar disorder also have migraine. They go together very often. The exact reason for this is not known, but it's thought that certain aspects of brain chemistry are the same for migraine and bipolar disorder. Migraine drugs such as Depakote, Topamax, and gabapentin are also helpful for bipolar disorder. There's a relationship with generalized anxiety disorder. It's called GAD. This affects everybody on earth. We have a little bit of this. We all have some degree of stress or anxiety. Some might not be able to talk about or identify it, but the experience of anxiety is universal. GAD has an increase of migraine, likely related to genetic brain relationship or insomnia. The number one trigger for a migraine headache is stress, which relates to anxiety. Half of persons with insomnia have GAD, the most common cause of sleeplessness. The GAD symptoms would be excessive anxiety and worry, difficult to control these symptoms on several subjects. The symptoms occur for more days, but not for 6 months. They cause significant distress or social impairment and have at least 3 ancillary symptoms of restlessness, mental tension, fatigue, poor concentration, irritability, muscle tension in the neck, shoulders, jaw, or teeth, grinding or bruxism, sleep disturbance. One German study of focal epilepsy and anxiety disorders revealed social phobia 7%, specific phobia 6%, panic disorder 5%, generalized anxiety disorder 3%, anxiety disorder not further specified 2%, obsessive compulsive disorder 1%, and post-traumatic stress disorder 1%. So there's a lot of relationship psychiatry between migraine and these disorders. Another common association is panic disorder. A panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time 4 or more of the following symptoms occur. 4 panic symptoms are required by the Diagnostic and Statistical Manual of Mental Disorders, 4th edition. Panic disorder is characterized by sudden, brief episodes of physical and mental symptoms which by definition occur spontaneously or out of the blue, to differentiate from an anxiety attack which had never occurred spontaneously and have always been secondary to a specific reason. For anxiety attacks, patients should have insight or a reason as to why the event occurred. Anxiety would come after a sudden attack by an assailant who wanted to kill you. There would be an evident reason for the symptoms resulting from such an attack. This is not true with panic disorder. And both panic attacks and anxiety turn on the brain's fight or flight mechanism. The symptoms could then be of panic disorder: palpitations, pounding heart rate or accelerated heart rate, sweating, trembling or shaking, sensations of shortness of breath or smothering, feeling of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded, or faint, chills or heat sensations, paresthesias, which is numbness or tingling sensation that can be face, arms, or legs, derealizations, a feeling of unreality like depersonalizations, like being detached from oneself, fear of losing control or going crazy, fear of dying. 1 or 2 attacks is called panic attack, but more than 3 panic attacks is called panic disorder. Many people with panic disorder will experience a migraine headache right after having a panic attack. This may be called simultaneous occurrence of panic attack and a migraine. Many of these patients with panic symptoms or tingling may get frightened to go to the emergency room. And the ER will usually check vital signs and do an EKG to be sure there's no heart disease and do a brain CAT scan to rule out hemorrhage or tumor. And then the patient will be later referred by the ER to see a cardiologist and neurologist to sort it out. Persons with panic disorder have more severe and frequent migraines. Risk factors for occurrence of panic disorder migraine are being female, having co-occurring agoraphobia, and depression. The prevalence of migraine in one anxiety disorder clinic sample was 67%. Anxiety disorder patients with migraine presented with a significantly greater number of comorbid psychiatric disorders than patients without migraine. All right, next I'm going to talk about agoraphobia, which goes with panic disorder. You can say panic disorder with or without agoraphobia. The incidence of agoraphobia of migraine is low, since the incidence of agoraphobia itself is only 2% in the United States. But panic disorder and agoraphobia often occur together. Agoraphobia is anxiety in which the affected person may fear and avoid places or situations that might cause panic symptoms or make the person feel trapped, helpless, or embarrassed. The lifetime prevalence of agoraphobia in the general U.S. population is 2%, with one study showing a high prevalence of 10% adults older than 65 years old. Despite its high prevalence in older patients, the average age of onset of agoraphobia is actually between ages of 25 and 30 years old. Agoraphobia is twice as common in women and is more disabling in women compared with men. During their lifetimes, 87% of patients with agoraphobia will also meet criteria for another psychiatric disorder, including panic disorder, social anxiety disorder, specific phobia, generalized anxiety disorder, and substance use disorder. The next subject is chronic fatigue syndrome, which is very common with patients with migraine. One study of researchers from Georgetown University found migraine in 84% of patients with chronic fatigue syndrome. The breakdown was 60% had migraine without aura and 24% had migraine with aura. Tension-type headaches were also present here in 81% of patients with chronic fatigue. Obsessive compulsive disorder, which is one of the anxiety disorders, has not been well studied with migraine, but one study found that migraine patients with medication overuse headache had more obsessive compulsive symptoms. Obsessive compulsive disorder belongs to the anxiety spectrum disorders and may be a comorbid presentation in patients with migraine. OCD seems to occur at higher frequency in patients with migraine than in the general population, but little information regarding this association is available. The last of these mental associations with migraine is attention deficit disorder and attention deficit hyperactive disorder. They both have an increased prevalence in migraine compared to controls for the general population. This is due to comorbidity between these two disorders of the brain, possibly related to their shared underlying pathophysiologies and comorbidities with other neuropsychiatric disorders like mood and anxiety disorders. In general, roughly 1 in 5 adults with ADHD will experience migraines, and the condition is more common in women than in men. One study found that migraine was strongly associated with ADHD. There was a significant interaction between age and gender, with comorbidity increasing with age and female sex. Post-hoc analysis showed that migraine with visual disturbances, migraine with aura, was generally associated with a higher risk of ADHD, and this was independent of ADHD phenotypes. Okay, so that's the end of my talk on this. A long discussion of the different medical psychiatric problems that can relate to migraine. God bless all you patients who have any of these conditions. I'll see you again on another broadcast. Good luck.